Welcome to your second submodule in Cognitive Care and Aging. In your last submodule, we debunked common myths about cognitive aging, and we described how brains tend to change with age. We ended our submodule with images designed to show how differently brains with common age-associated neurodegenerative diseases look and ultimately function. Here, we will deepen our discussion on neurodegenerative disease to meet two basic objectives. First, we will describe the behavioral problems you are most likely to encounter in elder care work sites. We'll describe them using both common terms and scientific terms. Then we'll help you understand why these behaviors happen in the first place by relating each of these behaviors back to the brain regions that produce them and explore how degeneration of those regions disrupts them. Let's get started. Reflect back on your years of working as a CNA. Has an older patient ever refused to take food or medications? Shouted at you? Refused to bathe? What time of day did it happen? How did you convince the patient to become more compliant? How did you feel about the interaction? These behaviors are often the reason that older people living with neurodegenerative diseases end up living in memory care units. They are challenging to deal with for their families, which also means they could be challenging to deal with for you. So let's take a few moments to understand why problem behaviors happen so that we can address them with knowledge, compassion, and professionalism. We'll begin our discussion of problem behaviors by first learning more about how diseases like Alzheimer's disease, Lewy body dementia, stroke, and Parkinson's disease develop. Then we'll focus on Alzheimer's disease, the most common cause of dementias, and learn about problem behaviors you might see in your work sites related to earlier stages of Alzheimer's disease. You're likely to encounter these behaviors in any clinical setting that serves older people, but you're most likely to see them in acute care, skilled nursing, or physical rehabilitation centers, and in assisted living. Later in this submodule, we'll learn about problem behaviors common to later stages of Alzheimer's disease and other dementias, like Lewy body disease. These behaviors are quite different from early-stage problem behaviors. They are more extreme and more likely to affect your physical and social well-being and require a different toolkit to cope with. Again, you will see these behaviors in any setting that serves older people, but you are highly likely to encounter them in acute care settings, such as hospital ER departments and in units that specialize in memory care. So how do dementias develop? Let's take a look. The first thing to know about the term dementia is that dementia is not a diagnosis. The brain is the seat of cognition and behavior. We say that a person has dementia when we see a combination of brain change and significant disruption to cognitions and behaviors that are extreme enough to interfere with daily life. The most common cognitive function affected by major neurocognitive diseases, like Alzheimer's disease, is memory, or the ability to recall facts, stories, episodes, or things you do in your day, or procedures for things you do all the time. Patients experiencing dementias may also have trouble paying attention, particularly when distracted or when focus is needed for long periods of time. They also have problems with executive functions like planning, reasoning, and making judgments. They typically have decreases in processing speed, which means that it takes them more time to respond when they hear and see information. Many patients with some kinds of dementias, like frontotemporal dementias, have difficulties forming speech. There can be lots of medical causes of cognitive function loss and changes in behavior that are consistent with dementias. Let's explore a few of those causes. The most significant neurodegenerative disease that causes dementias is Alzheimer's disease. Named for Dr. Alois Alzheimer, who characterized some of the disease's symptoms in the early 1900s, Alzheimer's disease accounts for 60 to 80% of dementia incidents. So why the range? If you work with patients in more acute care environments or in assisted living without memory care, you can probably answer this question immediately. There's a lot of denial and stigma where Alzheimer's disease is concerned. In fact, older people fear developing Alzheimer's disease so significantly that there are even surveys, like the Fear of Alzheimer's Disease scale, designed to measure the extent of that fear. You'll often know from your patient care duties that a patient might be suffering from cognitive impairment but the patient's family won't hear it or accept it. Or you'll hear from a patient's spouse or adult children that there may be a memory problem, but that the patient won't accept it. Either way, people have a hard time facing this disease. Diagnosing Alzheimer's disease also requires access to specialty care that doesn't exist in many communities. Whether it's diagnosed or not, it is one of the most important causes of dementia symptoms. Because it is so prevalent, we'll discuss Alzheimer's disease in more depth in just a moment. Before we do, though, let's take a look at some of the other major causes of dementia symptoms. Lewy body disease only accounts for a small proportion of cases of dementia symptoms, but the symptoms tend to be severe. We'll talk more about Lewy body disease momentarily. Accounting for roughly equal proportions of dementia symptoms are vascular dementias and frontotemporal dementias. Vascular dementias are almost undoubtedly underdiagnosed. We'll speak more about these momentarily. Frontotemporal dementias, while still a small percentage of cases, are increasing, along with all of the other causes of dementia symptoms. Frontotemporal dementias can render a patient unable to communicate verbally or inappropriate in their language use. Some patients become angry or irritable, combative, and prone to shouting and swearing. All of the major diseases that cause dementia symptoms are on the rise. Although we'll focus primarily on Alzheimer's disease in the rest of this module, it's important to know the differences between these diseases, since different diseases are more likely to cause different problem behaviors, which will require different behavioral management techniques to solve. Let's begin with Lewy body disease. Lewy bodies are deposits of a protein called alpha-synuclein in the brain, which you can see in the image on your screen. Brain cells communicate with each other using chemicals called neurotransmitters. In healthy brains, alpha-synuclein helps control how much neurotransmitter is released from one neuron to communicate with other neurons near it. In Lewy body disease, those proteins form deposits that interfere with neural communication. People living with Lewy body disease can have symptoms of REM behavior disorder, where they experience violent and disturbing dreams and cry out while sleeping or act out the dreams. They may also experience hallucinations, show aggression, feel depressed or anxious, and become inattentive. They may also become rigid, develop tremors, and have difficulties walking. Lewy body disease is not the only disease characterized by Lewy body deposits in the brain. Some patients with Parkinson's disease also have Lewy bodies, which may be related to some of the symptoms these diseases share, like sleep disturbances, tremor, and muscle rigidity. People with Parkinson's disease also have degeneration in a part of the brain called the substantia nigra. This part of the brain helps control movement. While not all patients with Parkinson's disease show memory loss, patients in later stages of Parkinson's disease often do. These patients also have trouble producing speech, writing, and eventually even swallowing food. They may also have REM behavior disorder and daytime sleepiness. As you can see in the image on your screen, brain activity in affected areas decreases over time, which is why Parkinson's symptoms also get worse with time. Finally, as more and more Americans experience high blood pressure and poor cardiovascular health, vascular dementias are also on the rise. Vascular dementias happen when parts of the brain are deprived of blood flow for long enough to damage the deprived areas. Some people have vascular dementia after a single cerebrovascular accident or stroke, which you can see in the image on your screen. At the site of the stroke, loss of blood deprives the brain of oxygen and nutrients it needs to survive. Not everyone suffers vascular dementia from a single accident, though. Others develop vascular dementia over time, from transient ischemic attacks or mini-strokes, and still others suffer cognitive loss from low-level reductions in blood flow due to poor vascular health. Problem behaviors in vascular dementias are as wide-ranging as the disease itself. To close out our discussion of other diseases that can cause dementia symptoms, we'll look at a few more causes of dementia that either aren't as common or aren't as easily characterized by a single brain problem. Let's start with frontotemporal dementias. Frontotemporal dementias are characterized by degeneration to frontal and temporal brain regions, which you can see highlighted by the arrow in the image on your screen. The frontal lobe is responsible for functions like impulse control, planning, reasoning, and problem solving. The temporal lobe is responsible for hearing, comprehending, and producing speech, as well as recognizing and naming faces and objects. As you saw with Parkinson's disease, a specific area of the brain, the substantia nigra, degenerated. The substantia nigra is responsible for movement, so it's no surprise that people with Parkinson's disease have problems with movement. Problem behaviors from frontotemporal dementias work the same way. When the frontal and temporal lobes break down, the problem behaviors we see tend to be related to emotion regulation, language, speech, and impulse control. People living with frontotemporal dementias may shout and swear, be unable to repress hurtful comments, and may have difficulties controlling their emotional responses. None of these behaviors mean that the patient is a mean, angry person, quote, on the inside. These behaviors are the direct result of damage to the brain. This is an important point to remember with all patients with problem behavior. The behavior is most likely directly relatable back to the brain region that is damaged and is not a reflection of who the person is now or was before the disease started. Let's move on to traumatic brain injury, or TBI. TBI is one of the major risk factors for Alzheimer's disease, but can, depending on the injury, also be a cause of problem behaviors. TBI is an injury, whether a closed head injury such as a concussion or an open head injury from an accident, to the brain. The more concussions a person has, and the more severe those concussions, the more likely that person is to develop dementia symptoms. With TBI, the injury tends to dictate the behavior. For example, a boxer who takes shots to the head might develop tremor. A soccer player who repeatedly does, quote, headers, or a football player who gets tackled often might over time develop chronic traumatic encephalopathy, which can produce behaviors similar to Alzheimer's disease. If you look at the image on your screen, you can see that brain activation in patients with CTE looks a lot more similar to brains with Alzheimer's disease than brains without disease. With TBI, the behavior depends on whether the injury is localized to a specific place in the brain or whether the injury is more diffuse. Finally, there are a lot of other causes of dementia symptoms that produce their own unique behaviors. For example, untreated syphilis infection can produce neurosyphilis, which can affect the tissue covering the brain and spinal cord, called the meninges, or it can directly affect the brain or the spine. People with neurosyphilis may exhibit changes in mood or thinking. Wernicke-Korsakoff syndrome can result from a vitamin B1 deficiency, most commonly caused by chronic alcohol use disorder or an eating disorder. The disease occurs in two phases. First, lack of vitamin B1 causes Wernicke's encephalopathy, which damages parts of the brain like the thalamus, which routes information from sensory organs, and the hypothalamus, which regulates temperature, appetite, and other vital functions. As B1 deficiency continues, patients begin to exhibit Korsakoff syndrome, which manifests as amnesia, disorientation, tremor, and vision loss. When you look at the image on your screen, you can see the cortical atrophy that causes Korsakoff syndrome. There are several other diseases that can cause symptoms of dementia, but the most important thing to remember is simply that the symptom matches the brain region affected by the disease. The symptom is not a reflection of the person as a whole, or that person's personality or, quote, goodness. The problem behavior reflects the underlying disease, and different diseases demand different behavioral strategies for management. Now that you have learned more about some of the diseases that produce challenging behaviors in elder care spaces, let's turn our attention to the disease you are most likely to commonly see, Alzheimer's disease. Perhaps the first and most important thing to reinforce about behaviors in Alzheimer's disease is that, good or bad, behavior originates in the brain. It's common to say things like, "If I could just get her to understand that she needs these pills," or "I don't know how many times I have told her that it is not 1958 and that she doesn't live in that house anymore." Depending on the nature of the patient's disease, though, helping a patient understand that medicines are necessary or what the current year is can be extremely challenging, and in the case of the current year, perhaps not necessary at all. The more we understand about how the brain supports behavior, the more realistic we will be in our expectations, and the better equipped we will be to help a patient engage in healthier behaviors. As you learned in your last submodule, age-related brain changes are gradual. Alzheimer's disease and the other diseases we just reviewed are not a normal part of aging. You may have heard the adage, if you have seen one patient with Alzheimer's disease, you have seen one patient with Alzheimer's disease. There is a lot of variability in how patients behave, depending on a number of factors, such as the unique pattern of degeneration present in each patient's brain. Before we focus on how individuals differ in their behavior patterns, though, let's take a look at similarities between patients. So let's take a closer look at the figure on your screen. We'll start with degeneration that quite often begins in middle age, but because patients do not express symptoms that can disentangle from stress, this phase of the disease is not usually detected. In this pre-Alzheimer's stage, neuroimaging can reveal changes in a few common brain regions, such as the medial temporal lobe, which is the part of the brain responsible for working memory and some of our most primal emotions, such as anger and fear. So how do you know when a loved one may be suffering from the earliest stages of cognitive loss? In this stage, you usually don't, and neither does the person with the disease. As we learned in our last submodule, brains are plastic. They can usually compensate for the relatively small amount of degeneration that happens in these preclinical stages. As time goes on, especially if there is no intervention to improve brain health in the earliest preclinical stages, preclinical degeneration may become more severe. Note how much time has passed between our earliest preclinical stages and our later preclinical stage. On average, this time marks the transition from middle age to older age. If degeneration continues, potential patients may start to notice very small, subtle changes, particularly in memory and emotion. They forget details of recent events, they forget names of people they meet, and they struggle to find the names of objects. Most people attribute these very mild symptoms to older age. Just as in earlier preclinical stages, many people with degeneration in this stage never progress on to full-blown Alzheimer's disease, and behavioral intervention at this point may help prevent the transition to the next stage, mild cognitive impairment. Over the course of older age, preclinical degeneration can become severe enough to become noticeable to the patient and to the people around them. For patients who started the disease process with medial temporal lobe degeneration, for example, close friends may notice the patient repeating stories, misplacing objects, and forgetting names. These behaviors can be a symptom of function loss in memory. Patients who started the disease with degeneration in other regions may have other noticeable symptoms. While these symptoms are noticeable, the patient is usually still able to live independently and complete instrumental activities of daily living, like taking medications and keeping appointments. This period of cognitive decline is called mild cognitive impairment, or MCI for short. As with the previous stages, not every patient with MCI develops full-blown Alzheimer's disease, but this stage is usually the first stage where older people or their loved ones seek the advice of a doctor. Many older people that you work with, particularly if you work in an acute care setting, will have symptoms of MCI, simply because metabolic and physical stress and illness can rob the brain of resources it needs to maintain normal function, even if only for a short time. Hospitalized older adults may have symptoms of MCI while hospitalized and recovering in skilled nursing settings, even if they fully recover and never progress to dementia. So let's take a few minutes and learn more about the MCI stage. When it comes to problem behaviors and early stages of the disease, like MCI, patients are usually aware that their cognition has changed, but may incorrectly attribute those changes to normal aging. Take a look at the chart on your right. You can see that while it is absolutely normal to lose things from time to time or to forget to do something, there is a qualitative difference in the types of things forgotten and a quantitative difference in how often those things are forgotten. An older person with normal cognition may occasionally miss an appointment or forget someone's name. With MCI, though, the patient and their family and close friends might notice that the changes are becoming more and more severe. MCI is not known for causing serious problem behaviors in most elder care settings, but there are a few behaviors to keep in mind, because these behaviors can impact the quality of care a patient receives and signal to that patient's care team that a cognitive screening and geriatric medical exam are needed. One of the most common behavioral symptoms of MCI is repeating stories. When we say repeating stories, though, we aren't referring to the sort of repetition that occurs in social gatherings when people relive old memories. In this case, the frequency of the repetition matters. A person with MCI may repeat stories more than once per week or even more than once per day. When you hear this kind of frequent repetition from patients, it's a sign that the patient should see a doctor. If the patient is Medicare eligible, cognitive screenings are part of the annual wellness visit. Just as patients tend to repeat stories, they may also repeat questions. We all have failures of encoding, where we ask a question, become distracted, don't actually process the answer, and re-ask the question. In a person with MCI, though, repetitive questions can happen multiple times per day, or even per hour. Once again, this is a sign that a patient should see a doctor for a cognitive screening and medical exam. We all have that moment at a party when we're introduced to lots of people and think to ourselves, there's no way I'm going to remember all those names. Some people are better at names than others. For a person with MCI, learning new names can be extremely challenging, and it's not uncommon to call one person by another's name. When forgotten names or mixed up names happen far more often than not, it's time for that checkup. Finally, people with mild cognitive impairment often hunt for commonly used words in normal conversation. Something kind of like, so I didn't like the TV show and I reached for the thing. The thing. You know, the thing with the buttons and the channels and, oh, remote control. When we're taxed or distracted, we'll all occasionally hunt for words. For a person with MCI, though, these words on the tip of the tongue increase in frequency. There are other possible symptoms of MCI. If you work in assisted living or life plan community environments, be on the lookout for these signs when you interact with residents. If you work in skilled nursing or an acute care setting, though, take special care. When older people are hospitalized for metabolic issues, undergoing surgery, or recovering from illness or a procedure, healing can use reserves needed by the brain to maintain normal cognitive function. This is true of any patient, but it is especially true of older adults who are also navigating the normal cognitive losses that come with age. When we explain care plans and discharge instructions to people with even temporary cognitive impairment, those patients tend to be more likely to readmit, which can affect reimbursement rates. Delivering quality care to someone with even temporary cognitive impairment means adapting your instructions and reminding and reinforcing those instructions during recovery. For those of you who work in skilled nursing, assisted living, and memory care settings, learning about how Alzheimer's disease and the other dementias we mentioned progress over time is important, since these diseases are usually progressive and in many cases terminal. When patients enter later stages of the disease, their problem behaviors change because the magnitude of degeneration in the brain also changes. Let's close out this submodule by taking a few moments to discuss what those changes might look like in later stages of Alzheimer's disease. Let's start by looking at a diagram of general disease progression. You can see that in those earlier stages of the disease that we just discussed, the degeneration is limited to areas responsible for working memory and higher cognitions, such as planning and judgment. As the disease progresses, though, you can see that the degeneration progresses to include more of the cortex by mid-stage and essentially the entire cortex by late stages. In the end stage of the disease, the degeneration includes regions of the brainstem responsible for breathing and heart rate. There are millions of people living with Alzheimer's disease, but Alzheimer's disease is not always included among the causes of death on the death certificate for several reasons. Although patients' families are not responsible for declaring the cause of death, families who are worried about stigma often ask physicians to leave Alzheimer's disease off the death certificate. If a person living with Alzheimer's disease dies from an accident, the accident is often listed as the cause of death, despite the fact that the disease often causes the accident. It is important that Alzheimer's disease be listed on the death certificate so that public health professionals understand the magnitude of the disease and develop policy and programming accordingly. When we think about problem behaviors in mid-stage, we often think about problems like disorientation, where patients have a hard time knowing where they are, what day it is, what year it is, and where they live. There are regions of the brain that associate visual information, touch and motor information, and memory function together, known as association areas, like the one shown here. These areas begin to degenerate in mid-stage for many patients. In your job, you may find that patients are angry, irritable, or suspicious of you. They may shout at you or believe you are trying to hurt them. They may resist taking medications because of these feelings, and they may feel anxious or depressed. It's vitally important that we not make assumptions about who a patient was before the disease based on these behaviors. As regions of the brain responsible for our survival-based emotions degenerate, these feelings can become intense, and lashing out is a natural reaction to feelings of threat that can't be inhibited since those brain regions are no longer able to serve that function. You may notice that people in mid-stage lose interest in food, or that they prefer to eat foods that are high in sugar. You may find yourself at odds with patients who refuse to eat the meals you provide. That happens naturally, because regions of the brain responsible for smell degenerate in Alzheimer's disease. Usually, simple tastes like sweet are preserved, but the complex flavors of vegetables that mask the more basic taste of bitter are no longer processed as effectively. Let's focus on one more feature of Alzheimer's disease that can cause problem behaviors. In mid-stage, the frontal lobe continues to degenerate. In addition to loss of higher cognition, such as planning and decision-making, patients often lose the ability to make sound emotional judgments and inhibit the emotions we all feel but resist the urge to express. Brains with Alzheimer's disease feel intensely and cannot effectively stop those intense feelings from coming out. When patients have intense expressions of emotion, whether joy, frustration, fear, anger, or sexual in nature, they lack the brain tissue necessary to keep those feelings inside. As patients progress into later stages, you can see that the degeneration becomes both more severe and more widespread. All of the areas that were affected in mid-stage degenerate further, and degeneration spreads to regions like sensory association areas that integrate information from all the senses and help a person feel grounded and present in a space. Patients in later stages may feel trapped in the past and may regress to behaviors that appear to be childlike but happen for different reasons. For children, inability to inhibit emotions that come from sensory experience happens because white matter connections are still developing and require experience to help them develop further. Patients in later stages of dementias lose preformed circuitry but cannot easily reroute neural pathways around the degenerated areas. Although visual function is one of the better preserved senses, even visual function can decline in later stages, and people living with the disease can experience hallucinations. Patients in later stages may lose the ability to speak in logically constructed sentences or understand language, which can make it difficult to check in with patients and understand their needs. Patients lose their ability to learn new faces and may only remember faces stored deep in long-term memory. When adult children age, patients may not recognize them because their only remaining concept of those children is from when they were young. It can be awkward for adult children to be confused with a deceased spouse because they favor that spouse when the spouse was that age. Although these are some of the more noticeable changes when we look at the cortex of the brain, there are also changes going on underneath the cortex that can cause problem behaviors. The disease tends to progress roughly from front to back, from cortex down to those more vital subcortical structures, and finally to brainstem. Buried underneath the cortex and toward the brainstem are the structures that control our perception of time, sleepiness, arousal, hunger, sexual drive, and even the ability to regulate heart rate and breathing. As the disease progresses, patients may experience sundowning, when the symptoms seem to get worse in late afternoon or evening. This happens because those areas of the brain that regulate arousal are also degenerating. Most of us aren't at our best late in the afternoon. The same is true for patients. Sleep disruptions are extremely common for patients living with Alzheimer's disease. They are often awake in the middle of the night, which can affect shift workers caring for patients on disrupted sleep schedules. In this submodule, we related disease states to the brain changes that define them and the problem behaviors that result from them. The most important point to remember is simply that problem behaviors arise from degeneration in the brain. Problem behaviors are not problem people. When we understand why patients behave as they do, and that those patients do not do so because they are, quote, bad people underneath it all, caring for them becomes easier. Alzheimer's disease does not reveal someone's true nature. Behaviors are simply clues we can use to know how the disease is progressing and where degeneration is happening. These behaviors may be natural and even predictable, but they can still be challenging to manage and can impact your well-being at work. In our next submodule, we will dig deeper into how to cope with these behaviors so that you can perform your personal and professional best. So thanks so much for your attention, and we'll see you in the next module.